Welcome, friends. This is Dr. Sharad Jaitly, your cardiologist from New York, on your favorite website, MuniMeterHealth.com, which is dedicated to teaching you and educating you about the human heart and its illnesses, and also helping enhance the clinical outcomes by combining the medical education and patient education from one end of the globe to the other. Thank you for watching MuniMeterHealth.com. I thank my medical fraternity, the growing general community for associating and bringing more friends and viewers to my site and showing the enthusiastic support and tremendous interest in this learning environment at MuniMeter Health. Thank you again. So without any further ado, as I always say, let's delve into the subject matter, and the matter of the subject being today, well, I'm going to discuss two studies here. One study will contain what's the role of stress MPI, or non-invasive testing, if you will, in a setting where you have extensive coronary artery calcium scores. Now, people are aware about getting coronary artery calcium scores. As you know, that's another way of understanding what your atherosclerotic burden is. Because we know coronary artery calcium scores are equal to atherosclerosis. Now, that's a given factor. Okay. Now, is that atherosclerosis significant or physiologically important? That remains to be answered. And therefore, if there are extensive coronary artery calcium scores, can we say comfortably that these patients can go for coronary angiography directly without going for stress MPI? So that's one question that we'll try to answer through this study. The second question that we'd like to answer through another study is, are stress MPIs important to follow after one has done CTA, for instance, or multi-slice CT, as we call them. So patients who undergo multi-slice CTs and have obstructive patterns of CAD, should they directly go for cardiac cath, or should they again go through have an evaluation of stress MPI first? So in other words, what is the role of nuclear cardiology? I'm coming back to the same. What is the role of nuclear cardiology in a setting where you have extensive coronary artery calcium scores, or in a setting where you have obstructive CAD pattern in a CAD, on a CTA? So let's answer these questions as we move forward. So I'll present you some of the studies here, for instance, and then we'll some data, and then we'll decide what the conclusions shall be. Well, if you look at the clinical history versus what's available right now, so say the clinical history alone will give you a suspicion of about roughly 50% of significant coronary artery disease based on clinical history alone. In other words, if you were to look at the CAD and there's a say of what's the chance of your suspicion in a general population where you're asking certain questions and clinical parameters, risk factors, etc., the chances are that, say, you have a 50% chance that you will suspect significant coronary artery disease. But that's not enough. And therefore, we have to come with other testing. So now, let's see if the ECG stress test adds any incremental value to the suspicion of significant coronary artery disease. The data is the following. You improve that by almost 60 to 70%, which we know that ECG stress test will improve your suspicion of significant coronary artery disease by 60 to 70%. One, by functional capacity, and two, by the ECG criteria which we follow. So these are the two ways by which one can incrementally improve in the setting of an ECG stress test alone. Now, let's see if you were to do a stress MPI. Now, stress MPI, the results are the following. You find that actually you improve it to by 80-85% in this setting. So 80 to 85% of these patients who have had an MPI, you will be able to suspect very comfortably that they have significant CAD. So what have we learned from this study? Clinical history alone gives you about a 50% comfortable zone. Combining that with an ECG stress test, which is, again, this is significant. Remember, the p-value is less than 0.01, so this is significant. you will see that there is a 60 to 70% it's an improvement to 60 to 70% of your suspicion to diagnose coronary artery disease. And here you have 80 to 85%, almost 90% sometimes, depending upon the labs. Myocardial perfusion imaging can do an incremental job in helping diagnose coronary artery disease. So with this base fact, let's understand what we can do to understand our thinking with the coronary arterial scores. Now, if you were to look at the studies the following way, say you have coronary artery calcium scores ranging from 25% to 50 to 75% and then over 90%. So this is your coronary arterial calcium scores. So, and here you have the abnormal coronary artery disease based on a stress MPI, if you will, and it has to have significant MPI to send somebody for revascularization. And the criteria for significant MPI or stress MPI being positive should be LV ischemia, if you will, to greater than 5%. We know that you have to have myocardial perfusion imaging defect of more than 5% to call it a significant MPI. We may have extensive MPI results by myocardial ischemia, but I'm saying more than 5% is considered as LV ischemia sufficient enough to send patients for cardiac cath and therefore intervention or PCR. So let's see now what percentage of patients who have coronary arterial calcium score of less than 25% will have an LV ischemia of more than 5%. Well, you will see, okay, let's on this axis, let's plan and say this is about 3%, this is 6%, this is 9%, this is say 12%. So you would still have about 1 to 2% of these patients will have somewhere along this range, 1 to 2% will have. In other words, patients who have coronary artery calcium scores of 25% will have 1 to 2%. Of those 1 to 2% will have significant LV ischemia. Now, let's understand what percentage of patients of coronary artery calcium score 50 to 75 percentile have LV ischemia. We are talking about roughly about 7%, if you will. So it comes out here. So we know about 7% of these patients shall have LV ischemia of more than 5%, requiring some intervention, etc. Now, with 90% coronary artery calcium scores, you'll be surprised that the incidence only goes as high as to 11%. It doesn't go too high. So in other words, what have we learned so far? That coronary arterial calcium scores, even of an extensive nature, it only increases your likelihood of sending somebody for treatable ischemia load by a cardiac cath after a stress MPI only by 11%. That means still 89 or 90% of these patients who have extensive coronary artery score of more than 90% will have non-significant MPI. So what have we learned here? The take-home message out of this study is very clear that one, a totally normal coronary artery calcium score less than 25% does not exclude presence of coronary artery disease. One. Why? Because 2% of these cases can still have myocardial perfusion defects enough requiring angiography and intervention. Take-home message. The second is extensive coronary arterial scores of more than 90% also only detect a minority of these patients to have a significant LV ischemia via stress MPI. So sending somebody directly for a cardiac cath, say if all these patients who had high coronary artery calcium scores and they all went for cardiac cath, is not appropriate either. So you may not want to send all the patients of coronary arterial calcium scores which are extensively high. And a lot of the times this is a myth. People feel that higher the calcium scores, higher is the atherosclerosis, which is true. But is that significant atherosclerosis which requires intervention? That is not true. Only 10 or 11% of these patients only actually have a significant stress MPI of more than 5% demonstrated ischemia. And those are the patients only should go for cardiac cath. So what have you learned so far out of this study? You have clearly understood that one, normal CAC, in other words, coronary arterial scores which are extremely normal or low, you'll still have 1 to 2% of these patients still have a positive stress MPI. You don't want to miss that. And two, extensive high scores of coronary artery calcium by imaging, by CAC imaging, does not require all these patients to go for angiography directly, because only a minority of these patients, like 10 to 11% of these patients, have a stress MPI which is significantly positive for physiological stenosis. And that is about 5% ischemia. So only 11%. So minority of these patients will require that, will be required to go for cardiac cath, only 11%. Moving on to my second study, which is here, as I discuss. And let's see if we can move this a little bit further down. Oops, went down all the way. So here we go. So when you look at this study here, where you have multi-slice CT, for instance, performed in patients where suspected CAD, and you try to correlate against stress MPI, which was significantly positive. What percentage of these patients who have multi-slice CT actually have significant MPI? So let's understand that. Patients who have, say, a normal, so there is a small group which has a totally normal multi-slice CT. There is another group which has a non-obstructive pattern, if you will, and these are non-obstructive varieties, so I call them NOCAD, non-obstructive CAD. And then there's another group which is showing obstructive CAD. So this is obstructive CAD shown as attained by multi-slice CT or CTA, if you will. This is CTA study. I'm sure you're familiar with that. So time and again we see these are anatomical tests, and we look at the correlation with a significant MPI requiring perfusion reversal, defect reversal. So in the normal setting, one sees that about almost, you would see 20 to 25% of these patients can still have myocardial perfusion defect. So that means that clearly states that getting a normal CTA does not imply that you do not have significant stenosis. So you still need a perfusion defect study after a normal CT, a normal CTA. 40% of these patients now, 40% of these patients who have non-obstructive CAD have a perfusion defect which is significantly positive. So here we have 40%. And this is about 50% or so. That means half the cases who have obstructive CAD will have a perfusion defect which is significant. So what is the take-home message out of this study? Well, multi-slice CT, if it is totally normal, will still have about 15 to 20% of these patients presenting with myocardial perfusion defects which are abnormal, and those cases still should require perfusion defect. You don't want to miss that chunk of those patients. Obstructive CAD patients whom you suspect that there is obstructive CAD based on a multi-slice CTA result, can they go directly for cardiac cath? The answer is no, because only 50% of these patients will actually require any further intervention by a PCI. Why? Because only 50% have physiologically important stenosis based on a myocardial perfusion imaging. So those cases will have to be still sent via myocardial perfusion imaging lab and then sent for cardiac cath and not directly for cardiac cath. So what have we learned? The take-home message is very clear that you have half the cases of obstructive CAD pattern based on a multi-slice CTA still requiring cardiac cath only after myocardial perfusion imaging. Very important. And yet patients who have non-obstructive CAD and yet who have normal looking multi-slice CT studies, they are almost 50%, 10, 15, and 40% here. So about 50% of these cases will also require a myocardial perfusion imaging before a cardiac cath is planned. And only about 40% of these patients, 40-45% of these patients will eventually go for angiogram. So the take-home message is very clear that that the non-interventional approach is still very, very important in a setting where whether or not you're suspecting extensive CAC scores, because we know CAC scores are equal to atherosclerosis, but we also know that even extensive 90%, say for instance the CAC score is, only 10 to 11% of these patients will have a positive stress MPI requiring treatably requiring revascularization, if you will. And obstructive CAD pattern seen on a CTA, only half the cases will actually require to be sent for cardiac cath, and those half cases must go via the myocardial perfusion imaging. So this way we can actually ascertain which of those half cases, 50% of those cases were sent for cardiac cath, and not everybody goes for cardiac cath. So in a nutshell, essentially speaking, the take-home message is very clear that stress MPI is the way to go, regardless whether you have CTA performed in these individuals, or regardless whether you have a coronary artery calcium score performed in these patients, because the chances are that even in an extensive coronary artery calcium scores, you'll only diagnose 10 to 11% of these patients to have coronary artery disease of a significant physiological stenosis, enough to be treatable by intervention. And patients who have CTA positive with obstructive CAD, only 50% of those patients will have significant stress MPI, enough to be diagnosed based on a CTA. So I thank you for your attention. This was a nutshell covering these two very important landmark studies in nuclear cardiology. Thank you again for watching MuniMeterHealth.com. Hopefully this was helpful. Until then, so long. This is Dr. Sharad Jaitly.